you or someone you love have scoliosis? Are you wondering what's next? What is life going to be like from now on? Or is this even a big deal? Hi, my name's Dave Butler, and welcome to the Scoliosis Experience. We are here to talk with real people, both patients, parents, and providers, to bring hope and clarity to the road ahead. Thanks for joining us, and let's get started. On today's episode, I talked to Dr. Michael Steinhaus and Dr. James Brewster, who are from the Intermountain Spine Institute, about adult scoliosis deformity surgery and what they do and how they treat it. So they talk about some specific things, one being what their surgical techniques for scoliosis and spine problems are, what procedures that they do, but they also talk about their philosophy with spine surgery and only doing what's necessary to help increase function and increase the quality of life for people. They talk about the best ways for a multidisciplinary approach with including other treatment modalities like physical therapy and chiropractic and acupuncture and things like that. They also talk about when to think about getting a second opinion, and the answer to that is that you should always get a second opinion, but it's interesting to hear them talk about that. They also talk about robot-assisted surgery, which is something that they do that not many surgeons in the area are doing. So I think this episode is a great one to listen to for anyone who is considering spine surgery or is worried about spine surgery, or someone who is searching for a spine surgeon. These two surgeons have been fantastic to work with. The patients that I've seen that have worked with them and that have received surgery by them rave about them. They love these guys, and that's why I wanted to do a podcast episode with them, because I have had such good reviews from my patients. Spine surgery is a highly debated topic among patients of mine and among people that I talk to about spine problems, and I think they clear up a lot of the misconceptions about spine surgery. And to be honest, I think these two spine surgeons are different than a lot of the spine surgeons and surgeons in general that most people have interacted with. So I hope you enjoy this episode. It's a great episode, and here's Dr. Steinhaus and Dr. Brewster. All right, welcome to the podcast. I'm sitting here with Dr. Steinhaus and Dr. Brewster, who are amazing surgeons in the Salt Lake Valley, and I wanted to sit down with them and talk about adult scoliosis and what they do for it, and what they have to offer for the patients that we see and the people that listen to this podcast. So thank you for agreeing to do this podcast.
Thanks for having us.
Yeah, thanks for having us.
Early morning on what is today? Tuesday at 7:30 in the morning, getting up before we see patients. So I appreciate that. A little background on how I know these two. I had a patient that came into my office that was raving about her surgeons, and most of the time, patients talk about their surgeons a lot, but she was pretty much raving about you guys, and I was like, I need to meet these guys, because I'm always looking for good scoliosis and spinal deformity surgeons that I can refer my patients to. And so I set up a meeting with you guys. You met with me, we chatted a little bit, and the patients that I've seen since still rave about you. So I thought it would be good to see what all the hullabaloo's about, right? The surgeries that I've seen from you guys are awesome, and you've been a good support for us, and I appreciate that. So maybe introduce yourself a little bit. Let's start with you, Dr. Steinhaus, and tell us about yourself.
So I'm Michael Steinhaus. I'm originally from the Midwest, from Kansas City, Missouri, where I grew up and did schooling and all that stuff. And then after high school, I went out to Boston. I went to Harvard for college, and then down to New York City to Columbia for med school. And then I've been in New York actually for all my training. So I stayed there for my residency at Hospital for Special Surgery, and then I stayed on for a year of fellowship, where I really focused on kind of spine, minimally invasive spine, but also complex deformity as well. So got kind of the full breadth of training in that regard, and then came out here to start practice.
Awesome. So how long have you been here in Utah now?
Almost a year now. We came last summer.
Okay, cool.
Yeah.
Last summer, and you experienced our winter and are still experiencing our winter.
That's exactly right. The surprise snowstorms in April are still a surprise to me. So
right.
Getting used
cool.
to it. Yeah.
Awesome, Dr. Brewster.
Yeah, so James Brewster. I'm originally from here in Sandy, Utah is where I grew up. So I went to Brighton High School there, for anyone in Utah. But anyway, go Bengals. And then I went to the University of Utah for undergraduate degree, and then I went to Midwestern University, one of the osteopathic schools down in Glendale, Arizona, kind of the greater Phoenix area. And then I went to Columbus, Ohio, to Grant Medical Center and Ohio Health for my orthopedic surgery residency training, and then a fellowship at The Ohio State University. I had to say it correctly. So
Nice.
And then back out here, and we've been here the same amount of time as Dr. Steinhaus. So
Okay, cool. So one thing that I realize a lot of our patients and the people listening to this may not totally understand what training you guys have to go through to be a spine surgeon. So I don't know if you could just describe what that entails, kind of what your background is. Part of it is, why you're experts in the field. Tell us about that a little bit.
So it involves too many years of training is the answer, and my wife will be the first to tell you that. No, but so you do the 4 years of college and then 4 years of med school, and after that you go to residency. So orthopedic surgery residency is 5 years. And then after that, most people at this time have done a fellowship in spine, especially if they're doing spinal deformity. It's a really good thing to have had, a specific year of training in spinal deformity. So that's an extra year on top of residency. And so you'll see spine surgeons today that are either trained in orthopedic surgery or neurosurgery. And I think at the end of the day, a fellowship trained spine surgeon, we all kind of, at this point, kind of do the same thing. So that's a slightly different path, and their residency is 2 years longer, I think, than the orthopedic surgery path. But regardless, a long haul.
That is a long road. That's what makes you experts in the field, because you have had that long road. So that's cool. So give us an idea what made you interested in spine surgery and maybe specifically spinal deformity surgery. Give us an idea about that. Maybe Dr. Brewster, let's have you go first.
yeah, so I think what made me interested in spine was, one, I feel like spinal issues really inhibit patients significantly, and you can perform surgeries that really get patients to give them their life back, essentially. I mean, you get them back up and moving, you get neurologic compression that's now decompressed, and they can start to function in a much better way and have a much better quality of life. And so there was a big drastic difference, and it felt very meaningful to me for whatever reason. I think it was just because it was so impactful to patients as I saw it. In addition, I think the spine is an incredible part of the anatomical structure of the human body. I mean, it's very intricate. There's a lot of balance that goes on. There's a lot of musculoskeletal anatomy that is involved with it. And so the anatomy is just a very three-dimensional thing, which kind of really drew me to it as well, and understanding it, which is part of it. So,
well, you must like it because you spent years of your life learning it. Dr. Steinhaus, what about you?
Sure. No, I totally agree with Dr. Brewster. I think the only thing I would add, part of what really made me interested in spine was, I think, the evolution of technology over the last few years has been enormous. I think spine was actually a little bit slow to adopt new technology. Being able to use kind of more minimally invasive techniques, even in a setting of, doing scoliosis surgery, and that's using navigation and robotic technology to really make what we do more, accurate and more perfect than we can, with just using, our own hands. That really kind of drove me to the field. I thought it would really change over the next, 15 to 30 years. So I think that's one thing. And then just to add to what Dr. Brewster said, especially when thinking about patients specifically with scoliosis or deformity, those are some of the most, functionally limiting diseases or pathologies that we see. They've done studies looking at health-related quality of life, and it's up there with cancer, with these really chronic conditions that you think of are terrible, cancer, HIV, all these heart failure, all these really limiting diseases are, patients with scoliosis can have just as bad, if not worse, quality of life measures as compared to those patients. And so when we're thinking about surgery, it really is to get patients, from this really severely limiting situation to something where they can actually get back to enjoying their life. So I think that's what was impactful for me.
Well, I think it's interesting because you think when you're talking about that quality of life reduction with having scoliosis, it's not something that most people generally think about. I don't even think probably most spine surgeons recognize that, but for the most part, that's not communicated to the patients that have it. It's like, oh, you have scoliosis, and it's like, well, yeah, it's affecting my life, but that's never really addressed. So I think that's really
no.
cool
I think a
point.
lot of times people think it's a cosmetic, like largely a cosmetic thing, which is not, just not what we see and not what the data shows. So it's interesting.
Especially in the adult population too. I mean, that's where it's a lot more disabling.
Yeah, and that's the biggest complaint that my patients have, my adults with scoliosis. Sometimes it's that, I have a hump on my back or something like that, but most of the time it's, I can't walk for longer than 10 minutes or something like that.
Right.
So that's cool. So tell us what types of patients you like to work with. Like, what's your ideal type patient?
I think we like to see patients of all kind of walks, in terms of age, teenagers all the way up to the elderly, and then same thing, whether you have a problem with your low back or your neck or your thoracic spine, kind of the whole gamut. I think for both of us, probably what drew us to spine was not everything is the exact same, and every patient is their own story, and we really think about each patient as their own. So what I like about it is that it's not just one, doing one thing over and over and over again. It's seeing kind of a large variety of patients with different issues and thinking about each patient, in their own right, and kind of coming up with a formalized treatment plan.
Yeah.
I guess the answer, that's a hard question. The ideal patient would be the one that you could do the least amount for to get them to the best situation, I think. And that's kind of, both of our training is, one, emphasizing minimally invasive stuff, but sometimes there is the intent that you do have to do a little more than just what can be done minimally invasive, but we do still use minimally invasive techniques when we do bigger surgeries such as scoliosis or deformity as well. But I think the ideal patient is one that's motivated to want to get better, and we try and have a long conversation with the patient that says that we set realistic goals, expectations, because going into a surgery for scoliosis is a huge deal, and it takes a lot of time and effort for us and them being patient with us and understanding that it's going to be a journey.
Right. And I think it's an interesting thought that you're trying to do the most benefit with the least amount of disruption of the body, which is, most jobs, they're trying to do the most possible. You guys are trying to do the most effect with the least amount of your skills. So, that's an interesting way to put it. So what kind of procedures and surgeries do you guys do? You talked about, cervical spine, thoracic, lumbar. Just kind of give an idea of what those surgeries are that you guys specialize in, and give us an idea of what you do.
I guess we just start neck and go down. Neck, we do cervical disc replacements, we'll do foraminotomies or just posterior isolated decompressions just through a tubular retractor, just for single nerve impingement. So we'll do also motion sparing cervical laminoplasty, meaning we'll dilate the cervical spinal canal so that there's not as much pressure on the spinal cord for patients that have significant spinal cord compression. And then obviously anterior cervical discectomies and fusions, and then posterior cervical fusions as well. Thoracic spine, from just simple decompressions, laminectomies to corpectomies to osteotomies. Those are all big words, I guess we could say. We're going into a lot of things. And similar in the lumbar spine is the same stuff.
Yeah. You mean you guys basically do anything spine related? Is kind of
and I think we try to the history of spine, I think, has involved a lot of fusion, and obviously there are certain cases, especially in the case of spinal deformity or scoliosis, where fusion really is necessary, but where possible, I think we try to do, again, kind of like Dr. Brewster was talking about, we have our philosophy of care, if you say that, is kind of like a minimally invasive or least invasive way to get somebody back to doing what they want to do. And oftentimes that's preserving motion, So I think a lot of what spine surgery in the past has been is fusion, all the way up and down the spine. And so I think we're trying to think of ways to keep your motion by doing disc replacements and some decompression only without fusion surgeries to allow patients. Because I think a lot of times, a lot of people think of spine as spine surgery as kind of a nightmare because they've heard these terror stories from friends or family, whatever, who spine surgery started and then it never stopped. And I think that happens when people start getting fusions that maybe aren't so necessary. And I think the best way to tackle that is to allow people to keep their motion and not put stress on adjacent levels and all that stuff. So I think we really try to, where possible. Obviously, sometimes it's necessary, but a lot of times it's not. So
I think we all know someone that's had a spine surgery. That all of my patients, my grandpa had spine surgery and it was never the same, and I think that point is very appropriate, and it kind of goes along with what you were talking about before, where you said that spine surgery seemed to be a little bit behind the times with technology and things like that. I think as that catches up, hopefully that's not the case anymore. Would you agree with that?
Yeah, 100%. Yeah.
A lot of times people think of spinal deformity surgery as just fusion. And what are the other options that, say, someone with scoliosis has that's, an older patient that has pain or is worried about it progressing? What options do they have as far as with you guys?
Well, I think, first of all, we're always proponents of people exhausting all non-operative options before surgery. Anytime you think any type of spine surgery, whether it's the smallest little thing you're doing or a big, scoliosis correction, is a surgery nonetheless. And so I think we try to avoid surgery at all costs and leave it kind of as a last option for people. But I think the other thing, like when you see a scoliosis on an x-ray, people immediately think, I have to straighten that. I have to make them perfect. And I think that's not necessarily the case. It's much more important to find out exactly, that's why we really take our time to go through the history and the physical exam and things like that to correlate what the pain or the problem this specific patient is having and how that's related to their specific case, rather than, we just look at an x-ray with a crooked spine and need to make it straight. So oftentimes people have one, even if you have a scoliosis, you have one level of a problem or even a small little disc herniation or one little area that needs a decompression, and you don't need a big scoliosis correction. So I think it's really kind of taking the time to think about, where are your symptoms, how does that correlate to what we see on the exam, and how does that correlate to what we see on imaging, and kind of to our point before, what's the smallest intervention we can do to get you back to a functional life? Because oftentimes, and maybe even more than half the time, doesn't involve a big long correction of a scoliosis, and can involve a 1 or 2 level decompression even without doing a fusion or stabilization surgery.
Yeah, sometimes it does require a big fusion,
right.
But ideally, most of the time, it doesn't.
Yeah.
And it's ideally almost like journey that we have with these patients. We sit down, we will talk about the scoliosis a little, but it's also kind of honing in on what are your symptoms, which oftentimes, as we're honing in those symptoms, that takes time. So we say we were trying a lot of these other non-operative modalities. We're trying physical therapy, plus minus chiropractic, plus minus, water therapies, plus minus injections, and medicinal treatments. And from that standpoint, that kind of helps us hone in on saying, and after having a discussion with patients, it's kind of saying, hey, I want you to think about what are your symptoms, because oftentimes we don't see a patient that has scoliosis right off and we're saying you need a big surgery right now. It's often a discussion first of saying, let's talk about this, let's figure this out together. And it's creating a relationship, too, because it takes a lot of time to make sure we're deciphering and doing the right thing.
Yeah. The only other thing I thought that I might add is that physical therapy is such a huge part of this process, especially for patients with deformity. And I think we can get a lot of patients a lot better without surgery, for patients who haven't, seen a physical therapist. And the second point to that is physical therapy is not physical therapy is not physical therapy. It's not all the same, So especially for patients, the more complex your issue, the more specialized you need to make your therapy and your treatment. So there's a little bit of a plug for David and his group, but I think, just anecdotally from what we've seen with patients, going to someone who specializes in scoliosis treatment and therapy is so key, because it's not, you don't, go into somebody who's just seen a knee and an ankle and a whatever, and, who doesn't have that training in deformity. It's very specific training, and I think patients do really well with those techniques. So I think, seeing someone who's specialized in that type of treatment is really key to the process.
And obviously, I'm not going to argue with you there.
Yeah.
So,
oh, but
yeah, and I think, like you were talking about, exhaust those conservative treatments before doing something more invasive. I think we've all had those patients who are 70 years old and they have a 65-degree curve and they don't have back pain, and it's like, what's different between that person and someone who has a 20-degree curve that is constantly complaining about their scoliosis caused back pain? Some of that could be weakness doesn't need a fusion of that 20-degree curve, those types of things. So I think that's great. And I see so often that patients are told, just wait until it's bad enough for surgery. And I really don't like that answer, because there's so many other things that can be done. So I think you guys have a fantastic approach to that. If someone is listening to this podcast and they're wondering if they're a good candidate to come see you guys, what would determine whether they're a good candidate to see you? Who are those patients that you would want to see?
I think, honestly, any patient. We're happy to sit down and talk with anyone about it and go through kind of our full workup and that sort of stuff, which includes really kind of looking at their quality of life, looking at their health, what's their past medical history, looking at bone quality and where their bone quality is at, because before doing a surgery like this, we make sure their bone quality is up to speed. They've been on vitamin D, calcium. Sometimes they have to get on medications for increasing their bone quality, so that we can actually proceed with a deformity correction or scoliosis correction if we have that case. I think that's a lot of how we approach it, is sitting down and having a conversation, and it's having kind of talking from A to Z management. And that's what this is expectant management. It's saying, hey, you may not be to the point that you need a surgery at this point, but we may get there, and this is when we're going to get there. So, and the things that really push our hands to more getting to a point to surgery, it's kind of that tipping scale. Is it to the point where it's affecting their life every single day? Have they exhausted non-operative measures? Do they have neurologic compression that's maybe pushing our hand to get stuff going a little sooner? So are they having weakness in their legs? Or are they having worsening neuropathies, or just from compression of the nerves? So that's kind of our main approach, I think.
Well, I mean, it sounds like those who have spine problems could come in and get a consultation with you and figure out if they're the right fit for what you guys do.
Absolutely.
Yeah, from anything from a disc herniation that they're looking at to a big scoliosis fusion with neurological compromise. So that's great. We kind of already talked about this a little bit, but what other treatments do you suggest for your patients? I heard you guys mention physical therapy. I heard injections, medications. Like what's kind of your algorithm to figure out where patients go for treatment or what they need?
Yeah, no, I think, we touched on that a little bit. I think, kind of like we've been mentioning, especially if you have scoliosis, and the treatment, the surgical treatment for that often ends up being a relatively large endeavor. So as we talked about before, this ends up being kind of a journey. And I think a lot of patients, as we mentioned, can get better, before surgery with all those kind of non-operative things that we talked about, including really focusing on therapy and building up your core strength and your paraspinal muscles and endurance and all these things that maybe for so long have deteriorated because of pain and because of inability to get up and move around. I think that's why I think focused physical therapy is really good. If there are certain little areas that we can identify that would be good for targeted injections, that's always very helpful. And sometimes those injections can last for months and months and really get people to a place where they can actually participate in therapy better. So they all work, I think, in concert. It's not just siloed treatments where, okay, I tried physical therapy for 6 weeks, that didn't work, so then I'm going to go try injections. I think they kind of work together. So I think putting all these things together can really make somebody better. And it's a journey. It's not like in the first week we'll see results and then that's it. It's you may for a year kind of wax and wane and start to get better and then maybe start to get a little bit worse as the scoliosis progresses. So I think just getting plugged into a system is key.
Well, and I think it's interesting you're talking about not doing siloed treatments, because I hear that all the time. Oh, I've tried physical therapy. I'm like, well, what did you do? What what did you do in therapy? Or I tried injections, but it just came back. I'm like, well, what did you do while the pain was gone? Things like that. So I like the idea of kind of a complementary approach with those different treatments. Dr. Brewster, any thoughts on
the only thing I'd add is I think as a patient that's going through the process of this, I think you have to kind of step back and say, all right, I'm going to be in the driver's seat of this. And you can't be too passive about your care, because you may end up, hopefully you get to the good specialist that really understands what's going on so they can really jump into it. But if you're going to the physical therapist, you got to say, I need you to teach me a home exercise plan. I need you to show me what I need to be doing of what proper lifting mechanics. How can I help prevent further progression? And it's asking kind of some of these questions to those that are treating you, what else you can do. In addition, it's trying all the modalities, like I think what Dr. Steinhaus was saying. It's not just therapy, it's ultrasound, it's e-stim, it's acupuncture, it's all these things. And some patients, it's interesting. I've never been able to 100% figure out what's going to work best for every patient, but some patients, they come back and say, hey, I did dry needling and that was like the best thing for me. It gave me like a month of relief. Or I went to pain management, I had a few injections and had some nerve ablations, and that helped me significantly for a long time. And so I think it's what you were saying is it's a synergistic response and kind of going out there and figuring out.
Like you guys touched on before, that actually tells you things too, as far as what your recommendations are to these patients. If injections help, that tells you something. If physical therapy helps, it tells you something. It tells you that something is helpful in structure of the spine, what that is like. So that's great. What suggestions do you guys have for, let's say someone was just diagnosed with adult scoliosis, whether that's adolescent that has progressed, or degenerative scoliosis, or other spinal deformities, maybe kyphosis or whatever. What are your suggestions for that person?
I think so if you were just diagnosed with scoliosis, I think it's kind of stepping back and saying, all right, talking to the specialist and figuring out, hey, is this more urgent or is this more something we can monitor and start to manage, that sort of thing. And that's really determined whether or not if you have neurologic compression and weakness that may push our hand to say, hey, we probably should do something sooner. If not, I think it's kind of saying, all right, I've got something, now I need to manage this, and this isn't something that will just necessarily 100% go away throughout my life. I'm going to have to manage my symptoms and these issues throughout my life.
Yeah, I agree. No, I think there's kind of this negative connotation with spinal deformity and scoliosis, and if you get diagnosed, I think people it can feel kind of like a very negative thing. And so my first inclination would be to say, stop and take a deep breath. This is not the end of the world. A lot of people have scoliosis, and a lot of people live very happy, healthy, functional lives doing what they want to do with scoliosis, and we have great ways to manage it. But I think to Dr. Brewster's point that, knowing that you have it, it almost becomes now a responsibility for, okay, this is something we want to actively manage, and the best way to do it is get on it early and often. I think even if you're not incredibly symptomatic and you're diagnosed with scoliosis, it makes sense to meet with a therapist or somebody who could show you exercises, because we know that, if you strengthen your paraspinals and maintain your endurance, that's going to limit the progression of this condition, which can progress. So I think it's good to know early, and it's good to kind of be on it early.
Yeah, and stay on it. Don't put it in the background. Right. And I have scoliosis. What have you done about that? Well, nothing.
Right.
So yeah, take control. Kind of like what Dr. Brewster was talking about as well. Not being passive, being a little more an active participant in your care, because not everyone will have access to a therapist that is specialized or a surgeon who knows as much about that as you guys. So I think being an active participant, that's huge in any aspect of healthcare, right? So maybe one question that I just thought of, when would it be a good idea for patients who are listening to this podcast to get a second opinion? Like, let's say they get an opinion from one of your colleagues or another spine surgeon. At what point would you recommend that they get a second opinion?
Always.
I was about to say any time. It doesn't hurt our feelings whatsoever.
No,
I think it's good to get many minds on these issues.
I think particularly if surgery is on the table, I would say to myself or any family member that I have or any patient that I see, if you're going to have a spine surgery, I would always get a second opinion. And just like Dr. Brewster said, if we're giving the first opinion, no, we're never offended if people go and get a second opinion, because this is about the patient and how they're going to do, and you want as many people to agree on the right treatment as possible. So I would say always. 100% of the time.
Always get a second opinion. And recently I had a patient that I sent over for you guys to do a second opinion for, and she was very impressed with what you guys had to say, and I think it helped her to come to a realization of what she needed to do. Getting more opinions, then you can make a better decision. To a point, you probably don't need a 10th opinion. Maybe you do, but a second opinion, I think, is a great thing.
And this is interestingly, getting a second opinion from another surgeon. As surgeons, we get second opinions too. So when it comes to these cases, this is like if I see a patient that has scoliosis, deformity, I sit down, I go through what I'm thinking and what I'm doing, and oftentimes I sit down after and I say, hey, Dr. Steinhaus, I saw a patient today. This is a case that I looked at. What do you think? Does this make sense? This is what I saw. And oftentimes we have a lot of conversations, even if it's deformity patients to minimally invasive patients. We often have two minds on a lot of these cases going in that we're kind of convinced one way or the other, that push us one way or the other. So it's nice to have each other's support. One is a group here, but also just kind of coming up with plans for patients.
Right. One last thing, one last question that I had. Tell us about the robot-assisted surgery that you do. That's kind of, I don't know how many are doing that in the area as far as spine surgery with robot assistance. But tell us about that. Tell us about how that works, the benefits of it, and stuff like that.
Yeah, so it's the robot is really great. It's a nice way that technology has evolved to make us feel that we're doing safer and more accurate surgery. What it does is it takes images of the patient. We get preoperative imaging of the patient, and then we kind of correlate it with how the patient is in the operating room, and the robot registers all of the anatomy, so it knows exactly where everything is. So it's not like a driverless car where we're not, where we're looking at a newspaper and the car is driving and that we're there participating in surgery. It just acts as a second check and helps us be much more accurate. So the data shows with this kind of navigation and robotic assisted technology that we have much more accurate placement of all of our hardware, fewer revisions, fewer times where you have to take out hardware and put it back in, which is just the first time going in is the best time to get it right, in my opinion. And so, if we can, anyone who's had multiple spine surgeries would tell you it'd be nice to just do one. So that's what's really nice about it. And it takes some stress off of our lives, honestly, because it's a really great second check, and we're not just relying on our knowledge of basic anatomy. We're augmenting that knowledge with some really good technology. So I think it's been really helpful.
Does it reduce complications during surgery?
Absolutely, yeah. So, when we're putting, especially in a scoliosis surgery where we're trying to do correction, we're putting screws into the pedicles of the spine. And sometimes in a really rotated spine, those pedicles aren't so easy to find, or they're small, or they're deformed. And that's when it's really helpful, because if we're relying just on our own hands and human error, and there are times when things are put in not exactly a couple millimeters off, and their nerves are there, spinal cord is around there, and so it's it definitely cuts down on complications with regard to that.
Yeah, the more accurate you can be, I assume, the better.
Absolutely.
100%.
Cool. So any other suggestions that you guys have for those that might be listening to this podcast? Anything that you feel like this type of patient would benefit from understanding better, or hearing, or anything like that?
No, I think we touched on those points. I think, in cases of spinal deformity and scoliosis, it's kind of a team approach. It's not just a single person that should kind of be a part of your care. It's a team, such as kind of how we've aligned with your group about with working with the therapists, working with the pain management team. It's working with the surgeons, and it's kind of coordinating care to help make sure that we get the right stuff done at the right time. So I think that's the biggest thing, is team approach, positive attitude, hopeful to kind of get in the right direction.
I would also add, just don't hesitate to reach out and see somebody. I think if people worry that if they're going to go see someone who specializes in spine surgery, that they're committed to having a spine surgery, and that's not really the truth. I think it's nice to meet with someone who knows, the natural history of these things, and can talk you through the non-operative and operative side of things, even for someone who's not ready for surgery yet. I think it's a fine thing. So I in the mind of being proactive about what's going on with your body, I think it's always good to meet with someone if you have any questions. So no time is too early to reach out and get an opinion.
And I think one last thing would be is that I know sometimes when you think spine surgery and big surgery, it's a scary thing, and that's why we try and take our time with you or with these patients to really explain, hey, this is what can be expected after surgery, how we're going to manage your pain, how we're going to manage your outcomes, and this is how we have step A to Z for plans of how we can manage all these common issues that come up with these things. And so it's helpful to sit down and talk about them.
That takes some of the unknown out of the equation, definitely. So yeah, I think the bottom line is, don't hesitate to come in and talk to you guys. You guys have been great to work with. So if someone wants to come in and talk to you, get a consultation, what's the best way for them to do that?
They can call our office. So that, our office number is 801-314-BACK, or 2225.
Okay.
So that's one thing. We're in the process of kind of revamping our website. They can find us on the web if they Google our names at the moment. And then I think referral from the therapist, from your primary care, or even just calling directly the office, I think is a fine way.
I think that was great. I think it really helps patients and those listening to know where to go for help. Like you talked about a lot, the multidisciplinary approach to back pain, scoliosis, and spine surgery, I think is awesome. So I really appreciate you guys doing this with me.
Thanks for having us.
Yeah,
appreciate
thank you. Really
Thanks for your
appreciate
time.
it.